so we're going to today have the wonderful opportunity to hear from Dr. Wizdom Powell Hammond. Now I'm going to read some of her bio, and I'm going to try very hard not to ad-lib, right? So Dr. Powell is an assistant professor of health behavior at UNC Chapel Hill. She's also a faculty member at UNC's Lineberger's Comprehensive Cancer Center and director of UNC's Men's Health Research Laboratory. She was appointed by President Obama to serve as a 2011 to 2012 White House Fellow to the Undersecretary of Defense for the Personnel Readiness and the Secretary of Defense, Leon Panetta. Her community-based research focused on psychosocial determinants of Black men's health across the life course with an emphasis on masculinity and racial discrimination, combined impact on Black men's health, disparities, mental health, and healthcare systems. Now, I know Dr. Powell from being a part of the Ford Foundation's group on masculinity, the Scholars Network. But prior to that, she has done some fascinating things. She was the Robert Wood Johnson Foundation Health and Society Scholar at the University of California, San Francisco, and Berkeley. She is a member of APA Minority and Ford Foundation Pre-Fellow who received a PhD and an MS in clinical psychology and an MPH in health and behavior from the University of Michigan at Ann Arbor. She has won numerous awards, and I'm going to hope that many of you will be here tomorrow when she has a more intimate conversation about her path. For our purposes, we are delighted to have her to talk about Black Men and Justice. As you know, the Black Men and Justice series is really intended to offer a new and different perspective to the conversations that we have about Black men, and to really think more broadly about notions of justice. At John Jay, our mission is to educate for justice, so it is appropriate to have a series that begins to think about these issues. Dr. Powell is particularly special to us because she is a John Jay alumna. Right? She graduated from John Jay with a BA in forensic psychology, and while she was here, and she graduated summa cum laude with highest praise. She received the Thurgood Marshall and Malcolm King Leadership Award. She was also a McNair Scholar and received the Postbaccalaureate Achievement Program Alumni Award. She is a member of Delta Omega Honorary Society in Public Health, and she's published so much, it's quite embarrassing. But her work has appeared in the American Journal of Public Health, Child Development, Journal of Counseling Psychology, American Journal of Community Psychology, and Journal of General Internal Medicine. I am delighted to introduce Dr. Wizdom Powell Hammond.
I'm always humbled to hear people read my bio because you never read it yourself, right? Other people always give it. But I'm really even more honored to be back here at John Jay College, where I think I started my career and I got set on the path to the place where I am now. I'm really sad that we can't see the PowerPoints because that's going to change slightly what I'm going to do, because some of the slides have data and it's just hard to talk through that without having a pictorial representation. So I'm going to shift the format somewhat and have it be a little bit more open-ended, open discussion forum, so that you can ask questions about my work and I can sort of dribble in bits and pieces of the data as we go along. I'll do some introductory remarks, so as a way to ground our conversation together today so that we can set the stage, and so that you can hear a little bit more about me and what I've done and how I feel that social justice, this pathway to doing work around men's health, and this real commitment to understanding Black male health disparities was started. So I think it's important as health professionals who are doing work with social justice leanings for us to always interrogate our motivations for doing this work. As a population health professional, I feel a sense of responsibility to engage in work that challenges systems of oppression and to develop strategies that will disrupt and dismantle them. And this sense of responsibility is actually amplified by a long history of Black women's health activism in the US. And this activism placed Black women on the front lines of health reform and also often in the line of fire. And when I think about lines of fire, I'm particularly reminded of Eunice Rivers. And most of you will know that Eunice Rivers was the public health nurse who acted as a liaison between the men who were signed up for the Tuskegee study of untreated syphilis among the Negro male. And I'm constantly sort of reflecting on her legacy, of her intentions and how they got shifted somehow along the way. And they seem to give rise to a kind of benign neglect that made her not object what should have been objected as she persisted in the study. And as a woman about men's health, I work in her shadow. I mean, I can't enter a room without her legacy trailing me. And it's a constant reminder to me to enter spaces humbly, with constant vigilance and checks on my internal motivations for this work, and to have the courage to change course. If I find that my work leaves the circles of men and boys that I enter less better off than they were before I came. I want to also talk a little bit about what will be happening now are some slides that will show pictures of my grandfather, which is probably the most disappointing part about not being able to show them, just because he is like the silent voice behind this work that no one ever gets to hear about. They read the papers and they see the articles, and I do these academic talks, but his legacy actually undergirds all of the work that I do. I would say that the seeds for social justice and health activism work in my life were planted fairly early on. And some of my earliest lessons really came as I sat in the living room of my housing project department. My mother would be braiding my hair as she mused about racism, poverty, and structural inequality. She was really the first critical race theorist that I knew, because she understood intersectionality in a way that I never could. Her thesis, far more complex than I could offer now with my more than 20 years of formal education. And also her love for her father, my grandfather, also was a permanent fixture in our home. My grandfather died at age 50 from a preventable cancer. And his premature transition had an indelible impact on my current interest in Black male health. But also, it made me really want to, without even being consciously aware of it in the beginning, to try to figure out how to prevent other families from losing the Black men and boys they love, without which no viable community can exist. And so it's with these sort of historical experiences, familial experiences, that I've approached this work. And I wanted to spend some time today just talking to you about some general background on Black male health disparities, describing some of my health and social justice research agenda, and then I was going to present some findings, but I'll just provide some brief points about that work, and then talk about some of the reflections on leadership that I gleaned from the year that I spent working with the Obama administration. So, as many of you are already aware, Black males continue to live the shortest lives in our country. And in some ways, these racialized sex differences in life expectancy represent some epigenetic or evolutionary phenomena. And in fact, when we look at data, which will be on the slide now, so just imagine a graph, it suggests that male fetuses are more likely to be miscarried and die in utero or shortly after birth. Men also have fewer infection-fighting T cells and are thought to have weaker immune systems than women. So in some ways, when we look at the data, males start out biologically as the weaker sex. But we know that these differences in life expectancy are not fully explained by biological sex differences, because if this were in fact true, then we might see similar patterns of premature mortality rates among men from different racial and ethnic groups. But this is not the case. For example, when we look at, let's take two cases, cardiovascular disease and cancer. When we look at the rates for white men compared to white women, we see that white men have higher rates of cardiovascular disease in some cancers when we look at them as a whole. Now, some cancers parse it out, there are some differences. But when we look at the differences between African American men or black men and black women, we see a larger disparity. So we know that there's something else going on besides biology that's driving these disparities. And so my work really tries to understand what those causes might be. And there are a couple of guiding posts in this work that help us to understand what some of these factors might be. For example, we know that men in general, and these are generalizations because I'm sure there are men in this room who would not meet this criteria, but men tend to minimize health problems and wait longer after symptom onset to seek care. We know that men are less likely than women to get preventive screenings. If you're a male in my family, a limb has to be fallen off, something amputated, something dire before you seek care. But when we look at African American men or black men when compared to non-Hispanic white men, we see that these differences are even more stark. That black men simply don't seem to get as much preventive health care even when compared to white males. But one of the issues in this work, and what really made me, in addition to my family history and the legacy of black health women's activism, but what led me to really want to think about this work was that as a scholar, I was struck by the lack of studies that focused specifically on black males. And those that did so without taking a pathological perspective, ones that looked both at strengths and weaknesses in this population, but that also tried to tell us a little bit more about why some of these differences might exist within groups. So we know that not all black males have shortened life expectancy. My uncle, is 75 and going strong, will probably outlive me. So there are differences, and the question for me is, why is it that some black males are healthier than others? And that fundamental question is one of the driving forces behind my work. There has also been a call within the National Academies of Science for work to move beyond just race comparisons. Now, we know we don't get a lot of empirical mileage out of comparing groups. In fact, that work really just tells us where the problems lie. It does little to tell us how we might be able to intervene upon those problems, or even, in fact, why those differences persist. There's much more, in other words, heterogeneity within black males than there is between black males and white males. And my work tries to understand what those factors are, and specifically to look at the role that two race-related and one gender-related factor might play, or contribution it might make to black male health disparities. So there are two specific male health disparities outcomes that I examine in my work. One is preventive health care use and screening, as I alluded to earlier in my talk, and then black male depressive symptomatology or depression outcomes. And I consider the role that masculinity, which I'll define for you in just a moment, and two factors, medical mistrust and everyday racism, might play in contributing to those outcomes. So I'm going to just list 3 questions for me that are driving forces behind this work. So the first is, I wanted to understand, how does masculinity impact black male health status, their medical mistrust, and their subsequent healthcare use? And what role might everyday racism, a term which I'll define shortly, play in black male depression or depressive symptomatology? And do the effects of masculinity and racism vary by age? Again, getting to this fundamental question of for whom are these risk factors harmful, and under what circumstances? So why does masculinity matter, and what am I talking about when I talk about masculinity? Well, I'm not obviously talking about male biology. So what I'm focusing really on are those male role norms or cultural expectations or beliefs about male behavior that are populous in our everyday discourse. For example, ideas like boys don't cry, that you should take stress like a man, that real men, bowl it alone or go it alone or make their way in the world on their own. And all you have to do really simply to overhear such norms being shared is just visit any playground in the US and watch a boy fall down and no one come to his aid really except to say, walk it off. So I think that there are implications for these kinds of norms that we don't quite understand. And I do think that there are positive and potentially positive and also less positive implications for endorsing such norms. But I want to talk a little bit about how these norms might shape the health behavior and health outcomes of Black males in ways that may be productive and in ways that may not. So the data tells us that men may forego getting health care as a means of demonstrating masculinity. That it's one way that men may show that they're tough and strong and capable of facing life stressors on their own. We know that men who have higher levels of masculinity are also less likely, or endorse these norms at a greater level, are less likely to get health care services and have more depressive symptomatology. But one thing that we know also is that the impact of masculinity on men's healthcare use and depression varies by the dimension that's explored. Masculinity is multidimensional. Men are multidimensional. And so we have to understand when we're doing this work, when and where, what norms are harmful, which ones are helpful, and under what circumstances. And I think that I'd like to just call your attention to two norms, which I know you won't remember without them on the slides, but I want you to try to hold these two in your mind, because when I talk about some of the findings, I think these will be critical to your understanding of what we found in the Men's Health Research Lab at UNC. So one dimension of male norms that we know is important and actually has been related to both positive and negative health outcomes among men are norms around self-reliance. And these are those norms that encourage men to independently solve problems and make decisions. And then there are norms around what we call restrictive emotionality. And these are norms that encourage men to shut down or suppress emotion. And these norms have implications specifically with respect to healthcare for what kind of trust men place in healthcare organizations and providers. But while we're considering norms among masculine norms among men in general, it's important also to remember that masculine norms vary by race and social location. For example, in some earlier qualitative work that myself and Jackie Mattis, who's a professor and chair at NYU, conducted together, we learned that Black men's definitions of masculinity are infused with a desire for redemption and proaction. We have since learned from other follow-up qualitative work that these definitions of masculinity are constructed really as a response to racism. And so when you're thinking about masculinity as a general construct, it's important to keep in mind that people bring to those definitions and enactment of those norms their history and their relative place in society. Some of the responses that we've noticed that are linked to Black male masculinity that are important for the work that I do is emotional stoicism. And some of you might have heard the term cool pose before. So how many people have heard that term before? Is it fairly new? So there's one hand in the audience, and someone I know, so I know you know what this term means. But cool pose really is a behavioral enactment strategy that some have said Black males, particularly residing in urban environments, may adapt as a strategy for keeping the world out. And so you might recognize this in everyday hip-hop culture as mean mugging, as other kinds of ways to display like emotional flatness. And one of the challenges with that type of adaptive response is that it pushes people out and it keeps you from going in. So when you think about healthcare system transactions, they require you to be somewhat vulnerable. To trust a physician or a healthcare organization requires you to sort of let your wall down. And so we know that for Black males that this strategy for keeping the wall up has a lot to do with them trying to defend or keep racism or oppression out. And when it comes to healthcare system transactions, we see this show up in ways that present as like longer delays in getting preventive health services screening, longer delays in seeking treatment after the onset of certain symptoms. And we know from the data that this way of being also helps to impact the trust that men develop in healthcare systems and organizations. the data tells us that medical mistrust is a barrier across a number of studies to Black Americans' healthcare use. And in fact, it's a barrier to everyone's use. We live in a highly mistrustful society for very apparent and worthwhile reasons. But for a long time, people just assumed that Black males' mistrust of medical systems had relatively little to do with gender, and were really all about the Tuskegee study that I referred to earlier. But I was really more convinced that medical mistrust was not just about what was happening in the past, that we didn't really need to look back 20 years to understand medical mistrust, that we could look at patient-physician interactions in the here and now and glean something about those that would tell us, give us more places to intervene. It's a pretty hopeless situation if all you have to go on is the Tuskegee experiment, because we can't go back and undo that. So I really wanted to understand more specific proximal factors that might influence Black men's medical mistrust. And the ironic thing about that is that one of my colleagues at Johns Hopkins University, Dr. Thomas Levis, did a study where he actually went out into the community and asked Black men and women about Tuskegee, just in a very blanket way, and asked them what happened there and what that study was all about. And how many of you think what do you think people said?
People don't know about Tuskegee.
Right. And when they were asked, they said, oh, the airmen, or anything that was, none of which alluded to the fact that any of them had a sort of real-time understanding of what that study was. Not in a way that is any, knock on their capacity to understand. It's just that we put a lot of weight on the Tuskegee study when trying to understand why Black males may or may not use healthcare systems, and that was not necessarily the most, important factor. And so my work has tried to sort of uncover what those factors might be. So I'll just tell you a little bit about one study that we did where we tried to understand more the factors that were happening in the here and now that might affect Black men's trust in medical organizations. And I think it's critically important for us to be thinking about healthcare, even at a time when we are moving more upstream and focusing on structural issues and really focusing on determinants that are far removed from the healthcare system. But I think the passage of the Affordable Care Act has potential implications to improve the reach for men and boys. And I don't really know that we know the full capacity of the healthcare system to contribute to health disparities among men and boys, because they don't go. So we can't get a full measure of the potential impact if they're not using the services. So that's just one caveat. So what I was going to say about the medical mistrust study was that we did most of the work that we've done has been conducted in barbershops across the U.S. We have been now in 5 states, and I'll tell you a little bit about our recruitment strategy. What we generally do is we have to first form a relationship with the communities in which those barbershops are embedded. So this is not work for the faint at heart, and certainly not work for those who may be slightly discouraged by a lot of no's. When I started doing this work, there were very few people that were in barbershop settings, but it's becoming more common in public health nowadays. So this is a picture of one of the strategies that we use to get men engaged in the study. So this is from one of our data collections in Augusta, Georgia. And we partner with an amazing one-stop shop for Black males. In fact, you could get your hair cut, car washed, and your dry cleaning in the same place. Now, there's a business idea for the entrepreneurs in the group, because I think they've since gone out of business, but I thought it was a wonderful idea. And it was really, to talk about brewing over with people. I don't know what happened with the business, but they certainly had a lot of folks coming in. So we partnered with them, and they made this sign for us and put it on the side of a highway. I'm pretty sure we caused a couple of collisions. The free haircut was a popular incentive, and what we did was we worked with the barbers first to train them on how to talk about the survey, because the survey was self-administered. And they were the front lines of communication for us, for all of our men who were enrolled in the study. They actually encouraged the men to fill out the survey while they waited. We chose barbershops that were high volume shops so that men would have a wait time. So my uncle, who's, I told you, in the 70s, he goes to a barber shop where he makes an appointment, and he expects to go in and get his hair cut and to be out of there. So that's not the kind of shop where this kind of work would be as viable, but we chose ones that were high volume, and we chose barbershops because it's a place where you can reach a cross-section of the population of black males. As a reminder of that, when I was doing this in Oakland, California, the mayor was in one barber's chair and a guy who was talking to me about his recent incarceration, and there was a dialogue happening. And most of us know that this is the case, but it was really a fascinating way to do this work. So we have about 800 or so men who are currently enrolled in the study or who have completed the survey. It was not a longitudinal study, so we don't have follow-up data, but we have a lot of data about a wide variety of experiences that black males have had. So I'm just going to forward to the medical mistrust. I'm not going to show all of these. I'll just go to the last slide. So what we found in our study first was that masculinity did play a role. The men who reported, God bless you, the men who reported higher levels of masculinity reported higher levels of medical mistrust. And this was after controlling for, when you control for things in a study, you try to figure out what you can hold constant. And so that you can get a better sense of how these factors that you're really interested in might have an impact on the outcome you're interested in. So we wanted to know, would masculinity make a difference after we control for health insurance status, after age, after level of education, after employment status, and even after we held all those things constant, we found that men who believed that real men should not disclose vulnerability to others were less likely to trust medical organizations. And then we also found that, I guess one of the things that take-home points that we made about the study, and a lot of